Thank you, and thank you so much for having me here. Tell me if you can hear me. I'm actually no longer the director of psychology in the Department of Urology. I expanded my hours in endocrinology, but I'm still in the Department of Urology. I just want to mention that. So I was daunted by this presentation because there was so much to say, and I wasn't exactly sure what all your background was. So I think the beginning slides may be stuff you already know, but I'll just whiz through that. So DSD can be referred to many different acronyms: disorders or differences of sex development, disorders of sex differentiation. One of the audience participants mentioned that talking about disorder or abnormality can be offensive to people, and another person in the audience wrote an article on nomenclature in this area, which can be a very sensitive issue. There isn't necessarily a name or a phrasing that everybody agrees is okay. Other terms are intersex, which I think people have adopted more and more to refer to DSD conditions, although many of my colleagues argue with that because some DSDs may not be considered intersex conditions. People also talk about individuals with ambiguous genitalia, atypical genitalia. Hermaphrodites, not used too much, but that's another term. Gender identity issues are sometimes present, but not always, and it varies by medical condition, and it's a very heterogeneous group of disorders, etiologies, and associated issues. And as I just mentioned, DSD terminology is often perceived as stigmatizing, and we don't have a good way to refer to DSDs with people because there's a lot of variation in the words that they'd like to use, and it's important to understand what how your patients feel. The incidence for specific DSD conditions aren't necessarily available, but the estimates are 1 out of 4,500 to 5,500 individuals are born with ambiguous genitalia. So an interdisciplinary model, there are different ways of depicting interdisciplinary models. It could be overlapping Venn diagram, or there can be arrows going from one to another. I chose this model, and these are some of the disciplines that could be involved in an interdisciplinary DSD team. And there are others that I didn't include, like law, for example, or legal. So endocrinology, urology is usually included, as is mental health, which could be psychiatry, psychology, social work. Nursing, bioethics, genetics, and gynecology can also be included. On our particular team at Boston Children's Hospital, we don't have bioethicists or gynecology in our team, and that may just have a historical reason in the way that the DSD program evolved. So I think it's different from place to place. We do have an ethics committee that we do sometimes draw upon their expertise and go to them when they're difficult cases, and it's been incredibly helpful sometimes. And I used to be on the ethics team, and it's a really interesting team. We do have genetics also on our interdisciplinary team. So the role of the mental health provider, I put this together based on my own experience as well as the literature. But I have to say, one of my frustrations when I started in this field was that I couldn't pick up a book or an article that really spelled out what I was supposed to do when I was sitting there with a patient. And the patients are different, the conditions are different, the concerns are different, the ages of diagnoses are different from patient to patient. So I kind of invented what I do as I go along. I'm not actually sure if other psychologists all do the same thing. We just developed a special interest group for DSD conditions in the Society of Pediatric Psychology, which is a division of the American Psychological Association, to try to share information about what we all do. But what I do, depending on the age of the kids, is psychoeducation, first and foremost, regarding how to promote well-being in your child. What does your child need developmentally? What kind of parenting does a child need? So this is not just a patient, this is not just a DSD baby, this is a kid. And basically kids with DSD conditions need what all other kids need, and we talk about that a lot, especially in a younger child. I also give guidance to families about their own, and parents about their own self-care and stress management, and try to see what kinds of supports they have and how they're doing and how it's impacting their relationships and their marriage. Or is this like we were just talking about cancer? Sometimes marriages don't survive a cancer diagnosis. With DSD conditions, that kind of stress can pull people apart or it can bring people together. Actually, a lot of the families that come to our clinics are really amazing, and a lot of them are very strong and solid families. I think we may not see all the families with kids with DSDs, and they may not make it in, but we also talk about what does this mean to you? What does this mean in your culture? What are your particular concerns individually? Everybody's unique. What are your worries? Often they are sexual function worries, like you were just talking about. What is this going to mean? Will my child ever be able to have a relationship when they're older? Are there cultural issues? We do get patients from all over the world, and the meeting within cultures of having ambiguous genitalia, of having sometimes an ambiguous gender, can be very, very different. Some families are very worried about it. Some societies are very gendered. Schools are male or female. If you're in the middle, it's not clear where you belong. I've had kids who actually were thrown out of several schools because of indeterminate gender issues, so that can be very difficult. So it's important to understand subcultures within the United States and if you have international patients. And also, these are kids and families who have other pre-existing stressors or life issues. I have kids coming in where there's other siblings. I'm thinking of some of my patients now who are undergoing treatment for cancer, or there are financial problems. I've had people come in and their primary concern is financial, like how am I going to pay for this? My deductible is $11,000. I have $500 in the bank. What am I going to do? So those are important things to understand about families and to see how you can help them and what are their strengths as well, what are their sources of support. And then one of the fundamental issues is guidance about what to tell others, often what to do about childcare. I've had families where they stopped working because they were afraid of finding a babysitter or a daycare center where they felt comfortable putting their baby who has atypical genitalia or ambiguous genitalia. So those are often huge concerns for people. What do I tell others? Should I tell my family? Last week, we had our clinic on Friday. I had an international family who said, it would be weird for me to tell my parents, and their parents were living in the home with them right now, had come just to stay and help with childcare, because in our culture, you don't share information that might upset other people in the family. I lied and said I was coming to a well baby visit. I didn't tell them why I was coming. So actually talking about the pros and cons and trying to figure out with families what's the best approach, because it isn't necessarily one approach fits all. I think it's really important to be very sensitive to the needs of the particular family you're working with. And then families also need guidance about sharing with their child and integrating a developmental perspective. Should I wait till they're 18? I have families who say, I never want to tell my child. Why would I ever tell my child? And having to go through why you actually would need to tell your child. I do have colleagues who won't see families in a DSD clinic unless they've disclosed the diagnosis to the child. But we do see families and we try to coach them, and usually people will come around. I find that even harder than discussing the condition with the kids for families is often fertility. Families will say, I can tell my child about their diagnosis, but it breaks my heart to tell them about fertility. And just this Friday, I had a family who said, I don't care about gender, I don't care about this condition, but the fertility issue is breaking my heart. And she started to cry. And she said, maybe it's because I'm a mother, and this is a newborn, that I just love being a mother so much. Having to deal with this with my child is so hard. So grappling with that and helping families disclose not just about the diagnosis, but about factors about the diagnosis is difficult. Sometimes we've had many kids come in with testicular regression syndrome who have prostheses, and they've never been told that they have prostheses, and now they've outgrown their prostheses. They're going to need new prostheses, and just coming out and telling them when they've never told them before is very difficult. hopefully with earlier intervention and earlier mental health, that won't happen as often. So we also provide guidance and support related to medical decision-making, including surgical interventions, other kinds of medical interventions, and help families go through these things. And I should say, all of this is predicated on having a good relationship between mental health and the medical providers. I can't talk to families about fertility or assisted reproductive technologies or surgery options unless I understand their condition, unless I have a good positive interaction and information sharing with the medical providers, because that's out of my scope. And you have to know, as a mental health provider, and the medical people have to know what's in their scope and what isn't, and roles need to be carefully delineated. And I also help to facilitate patient, the child, or the adolescent's communication with the medical team, as well as families' communication. Sometimes the medical exam is very stressful. I actually have a paper that I wrote with Lino Nahata and others on the medical exam. And there's not much research actually with DSD conditions. We did a literature review from another area, child sexual abuse, and exported it to the DSD area. But interviews of adult patients say that sometimes having a lot of people crowding around, taking photographs, looking at their genitals is very dehumanizing. Being able to have kids tell you, well, I would feel much better with a male provider or a female doctor is very important, or I didn't understand what they were saying. I've often had the medical people that I work with come in and re-explain things to patients, because they'll come in and say, I didn't know what they were talking about. And I'll coach my patients that it's their body. They have a right to know everything about their body. Don't look it up on the internet, because we are committed to telling you the truth. And we're going to tell you the truth, and I don't want you to go home and be embarrassed or be worried that you didn't ask something. I want you, and so I try to empower them to ask what they need, and if they have concerns about the medical exam, to ask about that. We provide resources for the family, and then a mental health person can help integrate a psychological perspective into a clinical research program, which we've tried to do at Boston Children's Hospital. So there are challenges working within an interdisciplinary context. One thing is it's often very rushed. Our clinics are very busy. Sometimes it's hard to have sufficient time with the patients. If you have an hour-long time blocked off, and then they come and say, well, I'm suicidal, and you have 7 other patients scheduled all in a row, or things emerge. Even medical tests come up that were unexpected and need to be processed. So communication is important, as I said, in interaction with the medical team. I just last week had a patient I was going to see at 8 in the morning. They had a likely diagnosis of CAIS, complete androgen insensitivity syndrome. I had seen them before. Usually if it's a new patient, I only see them after the medical visit so I could talk with the doctors, but they were a familiar family. But they had just had tests come in with a different, that actually disconfirmed that diagnosis, and with a different diagnosis. And luckily, I found the doctor, the endocrinologist. He wasn't with somebody else, and I said, I just want to confirm this is CIS before I see them, and he looked it up and said, no, it's not. And it would have been really bad to meet with them, talk about the implications of CAIS, have them go to the next medical appointment and be told, actually, it's not CAIS. So it's really important to keep abreast of things and to have a comfortable relationship and interaction. It can be difficult on interdisciplinary teams if people from different disciplines have different perspectives on what kinds of interventions are appropriate, whether disclosure or information sharing is appropriate and at what ages, what determines gender or what likely gender kids will be when it's not clear. And so it's important, again, to have good relationships and to be able to discuss those assumptions, come to consensus. I know of some teams across the country where they had to get outside mediators to come in because there were differences of opinion. And if you work in this area now, I know people at Lurie are familiar with this, as we are at Boston Children's Hospital, there are some very trigger issues right now, particularly related to surgical interventions with certain DSD conditions. And so it can be very difficult, especially when we have a lot of families who are pushing for surgical interventions that some of our surgeons are uncomfortable with. And so sometimes there's a tension when families would like more intervention and we want to be more conservative about it. It can go the other way as well. So it is also true that there can be power differentials between disciplines, that it may be that certain providers or certain disciplines in the end have final say over what happens or how you approach a problem. And there also can be power differentials within a discipline. So there can be trainees and senior people, and trainees may not feel as comfortable saying how they feel, even if they have perspectives that are valuable that should be shared, if they're intimidated. So it's actually helpful if people don't feel intimidated, if there's an openness in a team, so that debate is healthy. Differences of opinion with smart, educated people are to be expected, and so it's helpful if you can work through and discuss those issues. It's really a problem. I was on the ethics committee at Boston Children's Hospital, and one of the prevailing themes that came up when I was on that team over and over were when contradictory information was conveyed to families, they got very confused, sometimes got very angry, and they lost trust in the providers, because if somebody says you're not infertile and somebody says you are infertile, it sounds like nobody really knows what they think, and there's not consensus. So which professional do you trust? So that can be very difficult. It's important to make sure you're on the same page and you don't say different things to the same people. And that speaks to a role clarity among team members. Who is doing the fertility counseling? If there are fertility and sexual function issues, who's talking about what? And what are you saying? Are we saying different things? And along those lines, I found that it's very difficult if people are having important conversations with patients if they don't document them. So there are some 17-year-olds I've seen who do have fertility impacts of their conditions. I look in the medical record and there's no documentation of fertility discussions. So I don't know if anybody's talked about fertility with them, if they know about the fertility issues or not. And it is really important when there's a transition to adult care also, so that adult providers can have some sense of what a person knows. And also if they've engaged in decision making, if they say, I don't want to have kids, I don't want to talk about fertility again, everybody's talking about fertility, but I don't care about that, it would be good for that to be documented so it's not brought up all the time by different people. And also because many people have multiple medical conditions, if people in different clinics are bringing up the same issues, it can also be stressful for patients. And so care coordination is facilitated by adequate documentation. There are challenges specific to DSD care. As I said, they're a heterogeneous group of conditions and heterogeneous needs. It's important as a mental health person to educate myself to the extent possible about what the medical conditions are and what their implications are. I already said this, but there's a dearth of clinical protocols outlining best practices. Like, I haven't seen a protocol about the best way to bring up sharing information with others or fertility issues necessarily, not outlined specifically. And then I think a very important mental health challenge is that some youth with DSD conditions tend to frequently be seen in interdisciplinary contexts when they're available, but other youth with certain conditions are, when they don't need to see urology or gynecology, when they just need to see endocrinology, may not be seen on a DSD team, even though they have the same counseling needs. So kids with Turner syndrome, kids with Klinefelter syndrome, sometimes kids with CAH or congenital adrenal hyperplasia are just seen in general endocrinology, but the same needs about fertility counseling, about sharing information, about concerns about sexual function and medical decision making pertain to those kids. And so it's really important, if it's possible, to structure a way to integrate mental health into services for those kids, even if they're not seen in the same day in a DSD context. This is my opinion in any case. There are actually some guidelines suggesting that, for instance, with Turner syndrome, for instance. It's also true that the schedule of medical needs, when kids need to be seen for medical purposes, and the schedule for mental health purpose needs don't always coincide. So some kids don't necessarily need to be seen by endocrinology from the ages of 3 until puberty, but it would be really helpful to see mental health alone during that time because of issues related to sharing information with others, sharing information about the diagnosis. That's why we get kids coming back around puberty and they don't know they have prostheses, or nobody's ever told them about their diagnosis. So we've started to integrate having kids come in just for mental health, even if they don't need a medical appointment sometimes. There aren't a lot of outcome studies in certain areas, so I'm always, families, for instance, of young kids are often asking me, what does this mean sexually and for intimacy for my child when they're older? Or adolescents who have microphalluses might say, am I going to be able to have intercourse? And I'll ask the doctors. I don't know that in my scope of knowledge as a psychologist, but often the physicians will say, I don't really know. And that's hard. It's hard for people to live with. I think people can tolerate knowing their diagnosis and what's coming up better than they can tolerate ambiguity or just being told it's not clear. But you have to tell what you know. And I need, again, that interaction with physicians. Often I bring physicians in to talk about these issues so we can work as a team together. But it would be nice to have more research. So I think this is a plug for clinical research because it's very important in certain areas. There's also limited mental health training opportunities. When I started in this field, there weren't many places to go to learn about how to be a pediatric psychologist in a DSD clinic. That's one of the reasons we started the special interest group. And then many of my patients could help to process issues around body image, around intimacy fears, around feeling different than peers with somebody other than their family. They would like to see mental health people, but because we don't have training programs, we don't have postdocs typically. We've started a postdoc, but there's not a lot of people in the community who feel comfortable seeing these kids, and that's also really sad and problematic. And I would like to say, one person mentioned some people live in rural areas and don't have the opportunity to have sexual function interventions the way you're talking about today. That's true with DSD care. So there's limited care options for many patients. And there are also limited transition of care planning options for people transitioning to adult care. And in adult care, there usually aren't DSD clinics, so often we don't know what happens to these kids once they graduate from our programs. Many of us continue to see young adults, but eventually they don't want to come to a children's hospital once they're 30. So it would be nice to have better planning for these kids. So just to talk specifically about fertility a little bit, you know all this, I think, but there are fertility concerns for many of the kids due to a variety of factors. Some conditions with DSD tend to have possible fertility potential, like Turner syndrome or Klinefelter syndrome. There's unknown fertility potential for many conditions, and infertility is associated, total infertility right now with the assisted reproductive technology we have. Infertility is associated with some forms of DSD. It is recommended that fertility counseling and sexual function counseling take place for at-risk pediatric populations, and there's a lot of ethical and logistical challenges that were outlined by others who are probably here in this audience, but there are human rights considerations about certain surgeries. Even though surgery is controversial, especially gonadectomy, they're also common. There's a lot of unknown medical and biological factors, as I said before, which makes it hard to give guidance. It's also hard to know. A lot of kids are too young to give consent, and they may not really be able to give informed assent based upon limitations for how they can understand their later desires for children or sexual function. So there are issues involving that. It can be hard for parents who, just like with cancer, need to make decisions, and there's a time frame within to make certain decisions. And there's a cost. There's a cost involved with fertility preservation sometimes for families. So for some families who do decide to engage in some fertility preservation that's expensive, there may be a pressure on the kids as they get older to feel like their parents sacrificed. Maybe I feel a burden that I should have children even if I don't want to have children, just because of what my parents did and the decisions they made. On the other hand, providers could be reluctant to suggest fertility preservation for various reasons, including cost, and it can be a burden on parents. And there's limited, I keep saying this, but there's limited dissemination of specific best practice protocols for different conditions. So I'm just going to talk a little bit about very, very preliminary studies that I was involved with before I finished today, because I think I'm supposed to be finished already. One is, it was just a capstone project for a genetic counseling student at Boston Medical Center, and she worked with me a little bit, and her aim was to identify parental reported counseling needs for parents of children ages 0 to 6 with DSDs, and it was a descriptive quantitative pilot survey study that she did, and she gave me permission to talk about it. The measures were demographic form, and we used a parent self-report health-related quality of life for DSD form that was developed by Alper et al. In 2016. It was validated for parents of children ages 0 to 6 with identified DSD conditions. It's a 55 Likert scale item, a measure with 12 different domains, including a variety of domains: decision-making, role functioning, gender expression, social functioning, etc., healthcare communication. We recruited participants through our clinic, and we contacted 35 people. About a quarter of people agreed to be in the study. We didn't have any reimbursement or any incentive for participation. And the people the caregivers who participated had kids with 3 different DSD conditions: severe hypospadias, ambiguous genitalia, and Klinefelter syndrome. So most participants expressed confidence in all areas in all domains. The 2 areas that participants consistently expressed concerns about were worrying about their child's future relationships. 7 out of 9 participants responded always true or usually true, and only 1 participant said never true. And 8 out of 9 participants across condition responded always or usually true, worrying about fertility issues. And I know this is a very minor preliminary study, but as a new clinician working in this area, it was meaningful to me because it brought home how much people were concerned about fertility, which has only been reinforced over time. So it was a concern, the area of most concern across the 12 measured domains. And then I also want to just briefly give you some sense of some ongoing research that we have. It's a cross-site study with Nationwide Children's Hospital and Boston Children's Hospital that's funded by NIH. And we're looking at factors influencing psychosocial outcomes in DSD conditions for adolescents and young adults ages 12 through 26. Lena Nahata, who's here, is an investigator on the study, and so is Jennifer Hansen-Moore, who might be here in the audience. She was here yesterday. So anyway, the rationale is that individuals with DSD conditions often report decreased satisfaction with health care and are at risk for psychological comorbidities, although they don't have to occur, including depression and anxiety, and there's not a lot of understanding of the factors that positively or negatively impact well-being. The current guidelines recommend that interdisciplinary care includes psychosocial services, but as I've been saying, knowledge gaps limit the ability of us to provide anticipatory guidance and promote positive outcomes. So it's a prospective mixed method qualitative quantitative study. We aim to recruit 108 survey participants, 10 half adults, half youth, and 40 qualitative interview participants. We have about 45% of the qualitative interviews completed now, and about a quarter of the surveys completed. So in order to participate, you need to be within the specified age range and have ambiguous or atypical genitalia and/or discordance between genital appearance and chromosomal sex. Exclusion criteria include a significant comorbid medical condition, a significant active mental health condition that would preclude being able to give a consent or fill out the surveys. We don't want to disqualify people who actually are depressed or anxious, but only if it's very severe. Individuals with intellectual disabilities or cognitive delays, a patient or the parent for the younger children who is not proficient in English, or patients who have not been informed about DSD conditions. And one of our aims, and this is only one of our aims, we have several others, and one of our hypotheses are that infertility and uncertainty about fertility status will be associated with lower quality of life and resilience and poorer psychosocial adjustment. So I would like to mention that for the younger participants, we only asked about fertility if the parents said they had been told about fertility. So we have two different surveys for the kids who'd been told about fertility and the kids who we didn't know about fertility issues. Everybody had to have been told about their condition. So 5 out of the younger group had never been told, according to their parents, about fertility concerns, so we didn't ask them about that. So it left 8 younger kids who filled out surveys that answered fertility questions, and 10 in the older group. Altogether, we have 23 so far. We have about half male and half female participants, and these are the conditions that are represented. The most frequent conditions represented so far are CAH and isolated hypospadias. The second most frequent is testicular regression syndrome. And just to give you, this is obviously very preliminary, 55% of the total group said that they would like more information about reproductive options. 66% said they would like to have children in the future, and only half said fertility was ever discussed with them. It's interesting because for the adolescents, we were told that fertility had been discussed with them before giving them questions about fertility. For the adolescents, 75% said that they desired children, and 75% desired more information about reproductive options. With the adults, 60% said, 40% said basically that fertility had not been discussed with them, and 40% wanted more information. 60% said that they wanted to have children. So I should say they didn't say if they wanted biological children or not. That wasn't clarified. So basically, data collection's ongoing. We're adding, hopefully, more sites for recruitment, and we're also adding adult hospitals in Boston and in Columbus, Ohio for recruitment. We're hoping to complete data collection by the summer or fall of 2018, and we'll also analyze the qualitative data, including fertility and intimacy themes. But the conclusion is that fertility is a significant concern for both parents and individuals with DSD conditions, consistent with other research. Most adolescents and young adults report parenthood goals in the future. Many individuals treated for DSD conditions so far report that they received inadequate information or would prefer to have more information and more counseling on reproductive options. And we need standardized approach to fertility-related discussions and decision-making in DSD care. So, thank you very much.
So I just had, as usual,
Gwen's questions are hard.
A question if I don't, yeah. So I know that there's probably not a clear answer to this, but I was struck by what you said, obviously, about the need to document, and that's really important, especially if someone's saying, like, I don't care about this, I don't want to hear about it anymore. And how do we balance that with what seems to be best practices, which is to have an ongoing conversation and address it at various times across the development?
That's actually a really good question. I think sometimes you can revisit it later on, but give the families a break. In this case, I had a family say, every time I come in, somebody talks about fertility. I've had it. I don't care about fertility. And that wasn't the kid. So you can bring it up later when the child is ready for it. Or if somebody's saying, I've told you now, and they come back in 3 months, they may not want to hear it again. So you can revisit it in a year or two. I totally agree with you, Gwen, that it should be an ongoing conversation. Sometimes, as with oncology, for example, you need to have the discussions at the time. And if that's the case, you need to talk with them about why it's important and work that out. Sometimes adolescents, particularly, maybe Gwen will be talking about this later on, can be very impulsive, can say, I don't want to hear about it. They can not take a step back, and they may be in certain denial. And it can be helpful to revisit very soon. So the first responses aren't always last responses, and they're not even necessarily how people really feel. Sometimes first reactions are very extreme and people will take a step back. But if you've really had ongoing conversations, if you've basically used up the conversation, if it's been going on for a long time and a person is firm and you have explored their reasons, it may be time to give it up at a certain point. Again, we don't have good protocols for how to address that or how to determine that. I hope that helped. Thank you for having me.